Welcome back. We're to part 2 of chapter 18 and we're talking about suicides. It's the 11th leading cause of death in the United States. A completed suicide refers to a self-inflicted death, whereas an attempted suicide refers to potentially lethal acts that did not result in death. It's the 4th leading cause of death in adolescence. One can happen every 17 minutes. Half of the individuals are men between the ages of 25 and 65. 10 to 20% of individuals that have attempted suicide attempt again and eventually succeed. And 11 to 51% have a physical illness at the time. There can be a family history, and in males, they are typically older, white, and live alone. Clinically, you may see a patient present with hopelessness as a red flag. They may or may not state their intentions. You may note that they've started to give away possessions. They quit a job. They appear abruptly peaceful, and in the past they had not. There may be self-mutilation threats or attempts on their life. There could be hallucinations or delusions. When you're assessing these individuals, you need to assess for ideation, if there's intent to harm themselves, if they have a plan in place. You're looking for specificity, availability, lethality of the plan. There's also a scale to assess called the SAD personas, and you can find that on page 1067 under Risk Factors 18.3, and this will help you determine the level of risk. If you are concerned that the patient may harm themselves, you need to hospitalize for safety. You want them to be have decreased environmental objects where they might be able to harm themselves. You're not to leave them alone. It would require a 911 or EMS transport. There may need to be involuntary certification if they're unwilling to go to be hospitalized, and you may need to involve the family. If you've assessed for suicidal risk and it's felt to be non-acute, it's important to ask the patient if there's any weapons or stashes of medicines at home that could be used, and get those removed by either the family or police or friends. Important to treat the presenting symptoms. You want to offer medications that can help with the current symptoms that are non-lethal, only a 1-week supply with no refills. And then it's important to assess what past behaviors have been with this individual, because they can predict what might go on currently and what might happen in the future. You'll want to schedule a follow-up appointment within 24 hours, and if that is missed, you want to call the patient. You also want to be able to give verbal and written information for a 24-hour crisis hotline and what to do in case of an emergency, and then involving the family. When educating this individual, encourage them to avoid alcohol, for both the family and the patient. When the mood lifts with the use of the medication, there may be an increased risk of a suicide attempt. It's important to follow up with a mental health provider, refer to appropriate therapies, monitor closely, and involve support systems. If you've had a patient that has had a successful suicide, it's important to assess the family for their grief reaction, allow them to share reactions, refer to support groups, and then there are support, one in particular is survivors of suicide. Next, let's talk about some schizophrenia. It's a psychotic disorder which generally is characterized by disturbances of thought, departure from reality, hallucinations, delusions, and grossly impaired self-care deficits. It's considered a chronic and disabling psychotic disorder. Clinically, you may see symptom clusters. These can be found on page 1071 in the book for table 18.11. In the individuals that have schizophrenia, for males, the onset is in the early 20s, and for females, it's in the late 20s. The lifetime risk for schizophrenia is anywhere from 0.3% to 0.7%. It is a genetic condition and has environmental factors. It is felt that urban births, social adversity and trauma, heavy cannabis use, migration, and stressful life events have all been suggested to increase the risk of schizophrenia. We talked a little bit ago about symptom clusters, and there's 4 symptom clusters that are used to describe the disorder. There's positive symptoms, negative symptoms, cognitive impairments, and affective disturbances. So positive symptoms refer to those active qualities. These are symptoms that are abnormal and are seen with psychosis, and these could include delusions, hallucinations, disorganized thinking. The negative symptoms represent a lack of normal characteristics, so they may have diminished emotional expressions. They may not be able to motivate themselves to do purposeful activities. Some cognitive impairments are seen early in life with a steady decline after the onset of the illness, and then they can correlate to the function of the impairment. With these individuals, with their first first break, they require full medical evaluation. You need to be aware for substance abuse or any withdrawal. You need to also be aware if there's medication side effects. You're also looking for delirium or infections that could be causing some of the symptoms. Labs that you may consider ordering could be a CBC, electrolytes, liver, thyroid panel. You'd want to do a complete H&P and do a neurological and mental status assessment. You're also going to want to assess for drug and alcohol toxicologies, pregnancy tests, infectious diseases, do screenings on STDs, heavy metals, EEG, and brain imaging. The goal of therapy is to reduce or eliminate symptoms. On page 1077, there's a table 18.3 of your antipsychotic medications that are commonly prescribed. They're divided into typical and atypical antipsychotics. Your typical medicines include your anticholinergics, include medications that can have anticholinergic effects. They can have extrapyramidal symptoms, so that movement disorder. They can also cause tardive dyskinesia, the rolling of the tongue. Your atypicals can cause endocrine disorders, cardiovascular issues, diabetes, hyperprolactemia, and weight gain. One medication that I want to bring attention to is Clozaril. It's effective with managing schizophrenia that has negative symptoms, but there are guidelines for monitoring its use. It requires frequent labs and reporting. There is a national Clozaril registry. It can cause myocarditis, low WBCs, and low neutrophils. Next, let's talk a little bit about grief. It can be multidimensional. It's the loss of a loved one, a job, a limb, a state of health, a pet. It can be very subjective to the patient. It can last anywhere from 6 months to a year, and as we know from nursing school, there's different stages and phases of grief. The stages include denial, anger, bargaining, depression, and acceptance, and our phases include avoidance, confrontation, and accommodation. Some risk factors that may be associated with grief. For more complicated grief, if there was a sudden or a violent death, if the individual has had social isolation, if they felt responsible for the death, if there's been a history of traumatic losses, and if there's been extreme ambivalence or a dependent relationship. Treatment for grief, for normal grief, may require a short-acting sedative to help with the immediate symptoms, and for a brief duration only. If there's prolonged or complicated grief, an SSRI may be very appropriate to help with the symptoms. If you have a patient that is having issues with grief, you could refer them to a grief counselor. It's important to have early detection. Help them to prepare for the stages of grief, encourage expressions of their feelings, and educate them about any triggers that might impact their grief. Next, we're going to talk about some substance-related and addictive disorders. There are 2 different types: substance use disorders and behavioral addictions. And with the substance use disorders, these are conditions that are chronic with cravings. They have an inability to control their use, and they use despite significant consequences. Some of the products that could be used that are legal could be caffeine, alcohol, nicotine. Marijuana is the number one illicit substance. Often with these individuals, there may be having other mood disorder comorbidities such as substance abuses, anxiety, antisocial personality issues, schizophrenia, etc. Of the products that are used, tobacco is the leading preventable cause of death, and alcohol, as we might know, is highly correlated with the white college-educated male. When you're evaluating someone for substance use issues, you're wanting to assess, does it cause impaired control? Is there a social impairment? Is there a risky use? Is the patient developing a tolerance to the product? Would they have withdrawal issues if the substance was removed? Some questions you might ask or think about to determine tolerance would be, are they using increased amounts? Is there a persistent desire or unsuccessful attempts to decrease or quit? Is there excessive time spent obtaining or recovering what the individual is looking for? Does its use interrupt or stop important activities? And do they use it despite physical and psychological problems? With nicotine, we know that it's a mild stimulant that impacts dopamine, but the body is feeling withdrawal 2 hours after the last dose, and that withdrawal peaks at 48 hours and can last up to a week. When you're trying to help someone with nicotine overuse, abuse, for the treatment, 5 A's that you can use: ask, advise, assess, assist, arrange. Pharmacological wise, there are several different replacements that can help with nicotine. Those are found on page 1087, and some nicotine replacement agents can come as transdermal, lozenges, nasal sprays. There's also medications that help with urges, such as bupropion and Varinclin, Chantix. Non-pharmacological interventions would include cessation programs, and these are excellent to combine with replacement agents. Alcohol is another substance that can be abused. We know that it has a CNS depressant. It can cause short and long-term changes in the neuron membranes in the brain. Its effects are felt more by women. There are different criterias for alcohol use, whether it be low risk drinking, at risk drinking, or harmful drinking, and you can go to the National Institute for Alcohol Abuse and Alcoholism and get some more specifics on that. It's defined as low risk drinking, though, for men at less than 4 drinks per day, and for women no more than 3 drinks per day. At-risk drinking is when you are consuming volumes of alcohol greater than the guidelines. And harmful drinking occurs when the alcohol causes physical, psychological, or social harm. When someone is trying to come off of alcohol use, it's important to assess where they are with withdrawal and help provide appropriate therapy. Removing alcohol, its decreased use and cessation can have anywhere from mild to severe effects, which can include death. You can also use the CAGE assessment to learn more about the effects of alcohol on the patient. Attempts to cut down, annoyed about questions related to use, guilty feelings, and any use of eye openers. Benzodiazepines can be used to help with the withdrawal of alcohol, but it's also important to make sure that they are participating in counseling and refer to either an outpatient or an inpatient program. Other substances that you may see in practice that you're helping your patient to come off of could include cannabis, opioids, cocaine, or heroin. I'm going to encourage you to read more about these in the book. We're going to talk next about sleep-wake disorders. They impact approximately 10 to 17% of the population and can be anywhere from insomnia to difficulty sleeping. It's a multi-system that can be impacting the sleep and has to do with the regulation of serotonin. We know that there's different stages of sleep. The non-rapid eye movement, which has 4 different stages, and then the rapid eye movement, or REM, which is a cycle that occurs anywhere from every 90 to 100 minutes. There are different types of sleep-wake disorders, from insomnia to obstructive sleep apnea, substance or medication-induced disorders, or restless leg syndrome. With individuals that have sleep disorders, it's important to assess what their sleep pattern is, how it impacts their daytime functioning, what other health issues they have, over-the-counter medications they use, caffeine use, herbal use. You should always try to go to non-pharmacological interventions before adding medications. These will include a sleep diary, sleep hygiene, exercise, avoidance of alcohol, caffeine, and stimulants, and cognitive behavioral therapy. Medication should only be added after non-pharmacological methods have been attempted, and sedative and hypnotic medications can be found on page 1101 in table 18.6. It's important to educate these individuals after you have got them established on the importance of sleep rituals and sleep hygiene, exercise, a light evening meal, the effects of the medicines, and the potential for drug dependency on several of these medications. The next is on eating disorders. I'm going to let you review that in the book. I will leave those slides here though for you so you can review those. Let's next talk about ADHD. It's described as a persistent pattern of inattention. You can have gross motor hyperactivity, impulsivity, and this can interfere with social, school, and work functionings. It's seen in approximately 5% of school-age children, males a greater ratio than females. Seen as an early onset, and 50% are diagnosed by the age of 4. There is known to be a genetic component and a perinatal influence. There are postnatal CNS abnormalities that can be noted. It may be a comorbid condition with Tourette's, other learning disorders, genetic disorders, or psychiatric disorders. And adults must have a childhood onset of ADHD to be diagnosed with that. You're not going to just develop this in adulthood. Symptoms typically occur before the age of 12. And to be diagnosed, you need to have 6 or more symptoms of inattentiveness, which can include patterns of careless mistakes, not listening, not following through on instructions, losing necessary things, easily distracted, forgetful, or 6 or more symptoms of hyperactivity and impulsivity. And these can include fidgets, leaves the classroom or refuses to remain seated, runs or climbs, difficulty playing or engaging in quiet activities, talks excessively, and impulsivity includes blurting out answers, difficulty waiting their turn, interrupts or intrudes. And these symptoms must be present for at least 6 months and inconsistent with developmental levels. Differential diagnoses to include would be issues with thyroid, lead toxicity, iron deficiencies, fetal alcohol syndrome, age-appropriate behaviors, and any learning disabilities. You also have to rule out that there's not issues with neurofibromatosis, Turner syndrome, Prader-Willi syndrome, or Williams syndrome. And there's more information about those in the book. You want to assess for a family history because there is a genetic component. You want to see the status of the parents, know more about their academic performance, see how they act in an unstructured environment, know what medications they're on, and at what functioning level they are at. Lab-wise, you may want to check serum lead levels, do a ferritin, thyroid. It's known that early diagnosis and interventions equal better outcomes with ADHD. Table 18.7 describes medications used with ADHD. First-line stimulant agents are drugs of choice. There's 4 that have been approved for children and 3 for adults. In the adolescent, you may want to consider medication diversion. You want to make sure that they are not giving these medicines or selling these medicines to other individuals who it was not prescribed for. Behavioral therapy is important for children. This is something that can be used, or the educational system can help with CBT and medications for adults, and then also referral to behavioral specialists and appropriate programs. Education is very important in these patients on helping them to manage the disorder. There is a table, Patient Education for ADHD, on page 1113. Organizational skills are beneficial, time management, study strategies, and minimization of distractions. With children, it's important to assess periodically, every 2 to 4 weeks initially, to assess their growth, and if their growth is reduced by 2%, to assess for any potential problems. Lastly, we're going to talk about sexual assault, which is forced sexual intercourse. Sorry for the phone call. It can include both a physical force and psychological coercion. Can include vaginal, anal, or oral penetration, and include the use of foreign objects. The 3 key components is lack of consent, threat or use of force, or vaginal, anal, or oral penetration by a body part or an object. For individuals that have sustained this, it can be a life-threatening event. It's a violent act. In 60% of cases reported, there can be date or acquaintance rape. 50% of women do not label the experience as rape, though. Here are some statistics on sexual assault. I'm not going to read those to you. A little bit about the men who commit the rapes, the ages, ethnicity, and if alcohol is involved. Often it's definitely an act of violence, and is humiliating for the recipient. There's a power and anger expressed through the rape. It's often part of another crime, and typically the victims have been threatened. There is a condition called a rape trauma syndrome, and has 2 phases, both an initial in the acute phase and long term. In the initial phase, there can be 4 physical symptoms: physical trauma, skeletal muscle tension, GI irritability, and GU disturbances. There can be both expressed and controlled emotional response patterns. In the long-term phase, there can be increased motor activity, nightmares. There can be fears that may develop and can be labeled as a trauma phobia. Diagnosis is made by the patient complaint and forensic evidence. So forensic evidence needs to be collected within 72 hours. And if the patient wants to be anonymous, they can use a Jane Doe rape kit, which has a coded number assigned to it. It's always important to use a sane nurse if possible, and that's a sexual assault nurse examiner who is experienced and trained in in how to obtain the physical evidence, and then to help the lady or gentleman as much as possible. And even if it's not reported to the police, the exam is free of charge, so it's important that you and your patients are aware of that. There will be a sexual assault interview, a physical exam. There may be assessment if drugs facilitated the sexual abuse. Was a condom used? They're going to want to know about what hygienic activities have happened since the assault, and postcoital hormonal contraception. You're going to want to do prophylactic STD treatments, refer to OBGYN and urology if needed, refer to the local rape crisis center. offer psychological support, assess for physical safety. You're wanting your exam, your conversations to be in a supportive approach. You want the individual to be able to vent their feelings and involve family if that's what they so desire as soon as possible. And then, of course, education, you want to be sure to assess for PTSD, any drug or alcohol use, depression, and report any physical symptoms that need follow-up. And that is the end of this chapter. Thank you so much.